Good morning, ladies and gentlemen. It's my pleasure to be invited to give a presentation in this conference. My name is Professor Roger M. I'm the Secretary of Education, World Psychiatric Association, and also the President of the Hong Kong College of Psychiatrists. I'm going to share with all of you about the recovery-based service that is currently implemented in Hong Kong. And I'm interested in exploring whether recovery-based concept, a predominantly Western concept, can be applied to an Eastern community. Now, let me give you a very brief overview about Hong Kong mental health system. As we all know, Hong Kong used to be a British colony until it handed over back to China in 1997. So, as we all know, asylum care in the West started in 18,000 till around 1960s. We all know that it's called asylum care because during that time, mental health problems did not have any effective treatment. So basically, psychiatric institutions provide a safe haven to support and care for people with severe psychiatric disorders. At that time, this function was actually very important because a lot of people with mental illnesses, especially the severe ones, would not be able to sustain or function independently on their own in that period of time. So the asylum served as a very important social institution to support and care for people with severe mental illnesses. So as we all know, in Europe, there was a rise in Victorian asylum across the 1900s. And we all know that as in the 1960s onward, there were quite a lot of scandals around the care provided in asylums, including poverty and also potential abuses in these asylums. There were also unclear criteria about admission and discharge. So a lot of patients remained institutionalized in these asylums for years, and they did not have any prospect of returning to the community. And in Hong Kong, actually, the first asylum was designed based on the Victorian asylum in the UK. And this is the Victorian asylum in Hong Kong. It was located in the central part of Hong Kong. It used to be the only mental health hospital in Hong Kong in the early 1900s. And at that time, this asylum mainly provided psychiatric care to patients, mainly the Westerners and also the travelers coming to Hong Kong from the West. And the old work and the care provided by the medical doctors have all along been described as an authority. And patients were considered as passive recipients of care. And that was what's happening in Hong Kong back in the 1900s till the very current time in quite a lot of places in Hong Kong. So I'm going to talk about the concept of recovery briefly before I move on to discuss about the challenges and opportunities of recovery-based care in Hong Kong. And as we all know, medical recovery focuses on complete remission of symptoms and restoration of normal functioning, while social recovery emphasizes personal strengths and growth in the presence of persistent symptoms. So basically, we can regard the medical recovery as a deficit model that emphasizes the importance of remediation of deficits so as to restore normality. While in the social recovery model, we emphasizes the existing strengths of the patients and the coexistence of strengths and also weaknesses or problems associated with mental illnesses. In 2002, Lieberman came up with a set of criteria of symptomatic recovery, including absence of significant positive and negative symptoms, adaptive work and social functioning, cordial familial and peer relationships at least once a week, independent living, subjective satisfaction with life, self-esteem and stable identity, as well as participation as a citizen in voting, self-efficacy, and other civic areas. So as we can see here, Lieberman, it's a very famous psychiatrist, and he has advocated the importance of social recovery. But here we can see that there is still a very strong emphasis on the absence of significant positive and negative symptoms. And when we look at the evidence of symptomatic recovery, we actually found that some individuals did achieve symptomatic remission and restoration of social and vocational functioning. Also, in the past couple of decades, we've found that there are improved treatment for schizophrenia and severe mental illnesses, including the introduction of assertive treatment and early intervention. Both have actually improved the prognosis of schizophrenia. And so studies have provided some glimpse of hope and therapeutic optimism about recovery. Now, and apart from the symptomatic recovery as recommended by Lieberman, and we've also witnessed other proponents of recovery care. But in this area of recovery care, the emphasis is less on symptomatic or complete restoration of recovery of symptoms, especially positive and negative symptoms. Instead, it emphasizes more on the concept of social recovery, as I've just mentioned. These components of recovery include finding and maintaining hope, reestablishment of positive identity. It's very important to emphasize that it's mentioning about finding a new identity which incorporates illnesses, but retains a core positive sense of self. And the third component is about building a meaningful life, making sense of illness, finding a meaning in life despite illness, being engaged in life, and taking responsibility and control, feeling in control of the illness and in control of life. So in this concept of recovery, we emphasize very much on developing and utilizing existing strengths and fostering hope for people to lead a meaningful life despite the presence of persistent symptoms. from a personal recovery framework, we can try to understand how the above mentioned components could be mapped into different areas or different life roles. As you can see here, we emphasize on the importance of developing various social roles. We need to understand that not everyone would need to have a job. And not everyone would need to take up a volunteer job. The most important point is about personal meaning of recovery, meaning that what kind of roles would be considered as personally meaningful and important. So this is the very concept of recovery. And regarding relationships, it has never emphasized it or directed that a person in recovery should establish or maintain all types of relationships that we see in people without mental health problems. So it's again a very personalized view on relationships. And of course, identity is another important concept of recovery. It emphasizes the importance of having an identity, a new identity. But the mental illness part is only a part of the identity, but not the whole of the identity. Now, there is, of course, an understandable concern about this concept of recovery in service users and mental health service providers' view. When we are talking about recovery to service users, we tend to emphasize the importance of self-determination, of their roles, of their identity, of their relationships. We talk about stigma combat. We talk about personal choices, personal experiences. We talk about expert user participation. But from the provider's point of view, especially in the current era of medical legal litigation, providers are more concerned about risk aversion, the role of professionalism, and also the role of social control agency. So there seems to be some kind of natural tension between the service users and providers. And I think this is an area that is still in action, or I would say an ongoing tension between the service users and the service providers, especially in countries where recovery-based practices are still in its infancy. Now, when we talk about recovery-based practice, we emphasize several points. We talk about collaborative work with service users, and we talk about less doing to the service user, but more doing with the service user. We as service providers, we have to give up the concept that doctor knows best. And we have to understand that patients as experts of their own mental illnesses. So the dialogue between the service providers and the service users will be a kind of common ground dialogue that shares knowledge and skills. And in a recovery-based practice, we are talking about empowering the service users in making their own choices, in making their own decisions. And when we talk about recovery-based practice, just now we've talked about taking control and responsibility as an important component of recovery care. So in this respect, what we are emphasizing is that service users should take responsibility of managing their own mental health issues, while the service providers should also be taking responsibility to facilitate patients' choices and autonomy. But this facilitation of patients' choices and autonomy does not imply total abandonment of the care of the patients. Instead, we are allowing or encouraging the patients to make choices in the context of evidence-based practice. My example would be when a service user is asking for tailing off the antipsychotics, it's very important to give informed knowledge to the service user about the risk of relapse in the subsequent 5 years upon cessation of antipsychotics. While accepting that there is a high risk of relapse of nearly around like 80% in 5 years' time, we have to accept that around 20% of patients might still be able to be free of medications. And given this evidence, what we would suggest is to discuss with the patients about the importance of gradual tapering of medications, increased in monitoring of mental state while the patient is reducing medications, educating patients about the early signs and symptoms of relapse, especially early signs of relapse in the form of relapse signature, so that patient would understand the possibility of early re-implementation or early reintroduction of antipsychotics in the very early signs of relapse. So when we are conducting this mutually agreed cessation of medications, actually the service providers are not giving out this important role as the service provider. And just as I've mentioned in the example, we do not rule out any possibilities here. Instead, we agreed and facilitate the service users to try out things. And the frequent monitoring and consultations provided during the period of tapering or cessation of antipsychotics is actually a stringy safety net in order to ensure that patients will not be left alone without any treatment in the presence of frank relapse. And another important concept is about a culture shift in terms of using positive versus pessimistic languages. In my opinion, this is actually quite difficult part because in our training as the psychiatrist or even as a medical doctor, we are still focusing on the deficit model, and we focus a lot on describing symptoms, describing diagnosis, describing the consequences of relapses, and also the prevention of relapses. And remember, we have to identify resources outside the mental health service because, as I've mentioned, in order to fulfill other different roles and social relationships, these roles and relationships will not be possible without the access to other alternative resources. Now, there's a very influential article written by the recovery experts in the field around the world in the Journal of World Psychiatry in 2014. It discusses about the uses and abuses of recovering, it basically highlights what I've briefly mentioned about the potential misuses of the concept of recovery, including that recovery does not apply to my patients. Compulsory detention and treatment aid recovery, and like a recovery orientation means closing services. Recovery is about making people independent and normal. So, and it also lays out the important interventions of recovery, including peer support workers, advanced directives, wellness recovery, action planning, illness management, and recovery, strengths model, recovery colleges, recovery education programs, individual placement, and supported housing. So we can, this landmark paper actually provides us with a clear landmark about how recovery-based care should be implemented. Now, when we look at the concepts of recovery, which is a concept from the West, I'm interested to see whether these concepts can actually be acceptable from the perspectives of Eastern philosophy. Now, when I talk about Eastern philosophy, I'm interested in my culture. I'm a Chinese, so I'm interested in the Far Eastern culture, which mainly and heavily focuses on Confucian and Taoist philosophies. Now, in Confucian philosophy, we have a very strong emphasis on filial piety, meaning that everyone has a role in the society. And for each role, they have a certain set of rights and responsibilities. For example, as a father, you have the rights to be the breadwinner of the family. You have the rights to direct or instruct your family members, especially your children, to follow some of your suggestions or instructions. But you also have the responsibilities of taking care and protecting your children. And likewise, as a child, to the father, a child is also expected to respect the father, follow the instructions of the father, and also fulfill the responsibilities as a son. So when we talk about this concept, it actually comes very close to my view on therapeutic risk-taking. So as providers and service users, they have their own rights and responsibilities. And what we need is to respect each other's rights and responsibilities in order to fulfill the roles in a harmonious way. And this was actually promote harmony and which also called tolerance in the community. So I think this is actually compatible with the Western philosophy and also the Eastern philosophy. Now, for recovery, we talk about doing with the service users. In Confucian philosophy, we emphasize a lot about mutual learning between teachers and students. So we actually learn while we teach, and we also learn while we serve as a student. So in other words, the teachers, the students, like the service providers and service users, they actually learn from each other and they work together to enhance the mutual learning. So again, this is very compatible with the Eastern philosophy. And in the recovery concept, it emphasizes about no one knows best. And this is actually an important concept in Confucian philosophy about learning. So actually, no one knows best, and everyone has to learn continuously, and everyone can be a teacher to everyone else. So again, it emphasizes the importance of humility, tolerance, and openness to different views and ideas. So again, this is also compatible with the Western concept of recovery. In the Eastern Taoist philosophy, there is an emphasis of taking the middle way. So instead of striving for extreme success or extreme ambition, we encourage people to take the middle way, to keep in moderation of everything. So this is, again, the very important concept of yin and yang in Chinese philosophy. And for this yin and yang, I would consider this as very similar to the concept of balancing care for the service users and also fostering autonomy for the service users. So in my view, actually, the Western concept of recovery is very compatible with the Eastern concept. Now, I'm not going to talk a lot about the top tips for recovery-oriented practice, but you can see that there is a lot of emphasis on respect, on active listening, on fostering self-management, and also respect among the service users. Of course, as medical doctors, mental health professionals, we always ask whether recovery-based care is just a belief or just a value-based practice. Is there any evidence to support that this practice will actually be translated into better mental health care? So there are several randomized controlled trials nowadays that compared services with and services without expert user participation. And the RCT have actually shown that they have similar duration of stay in hospital, but with expert user participation in the service, there's a better acceptance of the service by service users. There is a longer duration of maintenance in the community before the first episode of remission. And also, there is enhanced self-esteem and interpersonal competence among these expert users. Now, so I'm going to share with you a bit about the local scene in Hong Kong. Now, in Hong Kong, we still have psychiatric beds in mental hospitals. Now, this is an old mental hospital in Hong Kong. It has just been recently renovated, but this picture was taken in the mid-2000s. So as you can see, around like 5 to 10 years ago, we still had psychiatric wards with a lot of beds. And in the outpatient service units in Hong Kong, you could see that the clinics are really crowded with patients because there's a very high demand for public mental health service in Hong Kong. Now, given the crowded environment in the psychiatric inpatient unit and also in the psychiatric outpatient unit, it's recovery-based practice ready in Hong Kong. Now, when we talk about choices, we also need to understand what kinds of choices are being available for people with mental health problems in Hong Kong. Now, in Hong Kong, living environment is very expensive. And as you can see here, a lot of people who are disadvantaged socially, they live in what we call petition spaces. So in a very small living petition space of like 100 square foot, 4 or even 5 members of the family can cluster together living in a very small space. So this is actually a very common phenomenon in Hong Kong, and it takes a very long time before the Hong Kong citizens can get to have a public housing unit in Hong Kong. For a general public housing unit in Hong Kong, the size would be around like 300 to 400 square foot for a family of like 4 or 5 members. So once someone gets a public housing unit, then the living environment can be much better. But the waiting time for such a public housing unit can be up to like 6 to 7 years, starting from the time of application. So before the availability of public housing unit, actually a lot of people would have to live in such petition spaces. So if we do not have a lot of choices, especially in housing, in work, and also in terms of time offered or allowed for patients in public health units, can we still have some kind of recovery-based practice being available in Hong Kong? My view on that is still possible. Well, this is a table about the levels of user involvement in the UK. And as you can see, actually, the so-called user involvement can be at various levels, ranging from interaction between users, interaction between users and professionals, and service users being involved in the management of local services, and also the highest level of involvement would be service users being involved in the planning of overall services. So as you can see here, when we talk about developing recovery-based practice in developing countries or even in Hong Kong, we can see that we can progress from one stage to another in a gradual manner. And for example, in Hong Kong, nowadays, we've been having service users being involved in the form of service users committees involved in the head office level in giving feedback and comments about mental health plans. So the levels of involvement can be gradual but promising. Now, this is a paper that I was involved, and it was a paper about how service user participation progressed in Hong Kong in the past years. So if you are interested, please feel free to get this online, and you would know better how service user participation has been developing in Hong Kong. Now, last but not least, I would like to discuss with you some of the views of various stakeholders during the time when we started setting up recovery-based practices in Hong Kong. Now, back in 2008, we did studies on understanding how patients and psychiatrists view recovery concepts. Now, it's very interesting that when we ask the chronic patients about recovery concepts, it's extremely interesting that they gave similar concepts, which were very in line with the psychiatrist's view, i.e., there was a narrow focus on medical recovery. Recovery meant complete cessation of medication and even termination on follow-up care, work, marital, social functioning as normal people. And there was a romantic view that if they had no illness, they would have no worry or troubles in life. And this view was actually very similar to the view of psychiatrists that we surveyed and conducted focus groups. And then we moved on to understand about the recovery view of the first episode patients. And very interesting, we noticed that when patients started having first episode, actually, they had a more optimistic view about full recovery. And they also had a positive view about the experience of psychosis as transformative and meaningful. But somehow that view gradually sunk into pessimism about recovery and a more romantic but unrealistic view about people without mental health problems. So it appeared that the view about recovery taken by the patients were actually heavily shaped by the views of the service providers, as well as by the service being provided by the service providers. So it gave a very important hint that if we wanted to help patients to develop a more positive view on recovery, the mental health services would also need to have a culture shift. So then we look into the recovery concept about the mental health professionals. So we did a survey on medical students, asking them about recovery concept, and then we asked psychiatrists about their view on recovery concepts. It's very interesting that medical students, to start with, they have a more positive view about social recovery, but within psychiatrists, they seem to have a more narrow view about medical recovery, and medical students would even accept having patients as friends and even spouses. But psychiatrists are actually very conserved and reserved about this kind of radical move. So we started to question how the institutions, how the training structures, how the training curriculum could have induced a change in views among the psychiatrists during the days of training. And of course, we were also interested to understand whether it was because of work bias, i.e. psychiatrists working in the mental health settings tend to see more patients with bad or severe prognosis. So, and then we also asked about the nurses' view on expert user participation in service delivery. And surprisingly, we found that nurses, to start with, believe that expert user participation would actually have a bad influence on the service users. They were worried that the service users would have relapse because of the stress of participations. They also worried that this would induce extra stress of monitoring mental state of the service users. So sounds like that the nurses at the starting point seem to have a very negative view about expert user participation. But when we surveyed the service users at that time, the service users actually viewed very differently. They believed that service users had the positive role models for other service users. They could be counselors to other service users. And in fact, they worried they worried more about provoking the staff, which they would regard as the stress of provoking relapse. And interestingly, they did not want to be paid staff with responsibilities, and they would actually prefer to be volunteers. So from there, we started to look into how we can enhance communication between the staff and the users. And we set up recovery training and competencies of staff in various healthcare units. And the strategies that we have done to move forward is in the form of expert user recruitment and also involvement of service users in planning, evaluation, and research in the respective local units. And the move was challenging, but it was rewarding. And because of the various work or the groundwork that we've done with the service staff, and we've been able to move on in the recovery service implementation in different units in a gradual but promising manner. Now, lastly, I think it's important that when we want to implement recovery services in a locality, it's important to look at the wider context. Now, in Hong Kong, the catalyst of developing recovery service are, number one, in the 2010 to 2015, we had a mental health service plan. And in the plan, we explicitly stated the need of implementation of recovery-based care. So this is a strategic direction that we always refer to when we provided training to staff and also education of service users about recovery care. And then in 2015, we started having the hospital accreditation exercise in Hong Kong. And in the accreditation exercise, we emphasized about patient empowerment. And this is a very important step, which served as catalyst to encourage our service providers and service staff to accept patients' involvement in service planning and evaluation. Now, the final catalyst is that there has been a very active discussion about mental health insurance in Hong Kong. And as we all know, mental health insurance emphasizes very much on consumer focus. So this is, again, an ongoing catalyst that we believe would be an important currency to bargain with the budget holders and also the policymakers of public mental health service to get more service users participation and involvement in various levels of recovery-based practice. So finally, my conclusion is as follows. And it's very important that before we start a recovery-based practice, it would be nice to have some research. And then we tried to develop some background training and set up competencies for the staff, and then engage the various stakeholders, take care of the catalyst available in the wider political and social perspectives. And then we gradually implement these strategies in a gradual and cautious but optimistic manner. So this is all I would like to share with all of you. I would love to have feedback from all of you in the form of emails or other kinds of conference comments. And finally, this is a picture. It's a metaphor about a frog in a well, a Chinese metaphor. I'm saying that I'm a frog in the well. I try to look at recovery from a very narrow perspective from bottom of the well. And I always would like to learn from all of you in the conference. So thank you very much for your patience. I apologize that I've overrun a little bit of this presentation, and thank you very much. Thank you.